Okay, that's on.
It doesn't work. Sheraz wrote that.
The same thing.
Where's he saying that?
Yeah, Gerd says the same.
I don't know why this is not working. It started. That's the panel one.
So Sheraz says, send us a link to the usual one and just make us panelists. So as they come in, you can just make them a panelist. I'm going to take that link, Sheraz, and I'm going to put it into the WhatsApp group.
Okay.
So try it now, Sheraz. Sheraz
I haven't now, but the other link that Chris sent was not correct.
Is this
Yeah,
one
but
working?
everybody else got in on it, so I don't understand why.
Well, I can show you my screen and show you what it shows, but it couldn't get in. It's
Okay, all right.
To host the meeting.
Sheraz, you are with my name at the moment.
That's good.
I've got
I
your
saw
name.
mine.
Because you said
You
your
should be able
name.
to change your name.
How am I going to do that?
Hang on, let me do that. Rename.
That's because I used Eileen's link, which is an iCloud. What was it?
Okay.
Yep. All right, so Sheraz is now Sheraz. Okay, now we just need to get the other two in. What did you send to them?
I got.
Oh, okay.
You got some WhatsApp and.
Yeah. Gerd has also the wrong link.
Okay, and that's so weird because I've been sending, all right. Okay, should we just open and then,
Yeah, let's go.
all right, let's go.
Good morning, good evening, good afternoon. I would like to welcome all participants. And here at our first Oracle for Eye Innovation. It's a great pleasure to have this fantastic faculty joining us. And before we jump into the different topics that these distinguished speakers will share with you tonight, I would like to give you a bit of the feedback on the idea or the purpose of this webinar. So we all participate in this cause. We're interested in innovation and in the future of how technologies and solutions can evolve in the ophthalmology area. And especially the speakers tonight, they have many, many years of experience being involved in developing new technologies and bringing them to the field and bringing it into the hands of surgeons and bringing it to the benefits to patients. So the idea of this webinar, which we are planning to host on a regular basis for the next couple of months, we would like to share with you the passion that all the speakers have being involved in innovation and in new technologies. And with sharing those innovations, also kind of give a little bit of an insight of how might ophthalmology and ophthalmic service to patients might look like, and how might the experience of a patient be in the future in our industry, in our area. I think we all appreciate, especially from the manufacturer side, the tremendous work, engagement, and involvement of clinicians working closely with early stage technology and supporting companies, researchers, and technologies to be applicable in the field of ophthalmology. And I think we also appreciate the tremendous amount of people working in manufacturers, industries, startups, or research area, having an interest in the field of ophthalmology and make patients see better or improve their vision. So that was kind of the idea. And looking at the situation of where technology evolves, we asked all the speakers to share with us what they think they want to get in their hands next. So basically, what is the technology innovation they think they cannot wait to get into their hands? Briefly, we have a very experienced and very exciting faculty tonight with Cummings, Gerd, Auffarth, Vance Thompson, Soosan Jacob, Sheraz Daya, and Richard Packard. As you probably all recognize, there's many years of experience working closely with new innovations technologies. And tonight, I'm very happy that they will share with them what is their latest thought, latest toy, latest idea they had a chance to work with. So I'm pretty excited to learn what these speakers have in mind, what they want to share with us in terms of the innovation they want to get into their hands. Now, one of the couple of questions we raised to the speakers, and I want to highlight also that the speakers were free to choose their topic. From a program organization, we just gave some directions by asking a couple of questions, but all the speakers tonight choose a topic that they are excited with, and they want to share why they're excited with this technology and innovation. I think we're going to raise the question, how does this change a life of a clinician by integrating this technology into the praxis? But for sure, we're also going to raise the question, how does it change the life of a patient? So basically, how does the innovation solve a problem that we are facing in the field? So by saying so, I would like to hand over to our moderator tonight, Professor Kilic from Medipol University in Turkey. And I would again welcome you everyone, and to this regular meeting we're planning moving forward. We already have set up a date on the 27th of July for the next meeting with a very exciting lineup, including Ike Ahmed and Ron Kruger and Damien Gattinel that we invited for the next series. By saying so, Aylin, I would like to hand over to you. So welcome and enjoy this evening.
Good evening. First of all, I would like to thanks to our speaker accepted our invitation about this meeting. And I would like to introduce a general basic about our program. First two speakers will talk about cornea, and Gerd and Soosan, Gerd Auffarth and Soosan Jacob. And second session, we will discuss about more cataract surgery. And after first session, after two speakers, we will receive questions. We will discuss, limited time, of course, and then we will continue. Now, I would like to introduce Gerd Auffarth. He will talk about artificial cornea for keratoplasty. Recently, he received award about this topic in video panel and in there a few months ago in ASR rating. Now, we look forward to listen, Gerd. Thank you so much, Gerd.
Yes, you're welcome. So I will open my screen for you so I can put my presentation up. So can you see my presentation now?
Yes.
Yes, and you can hear me, yeah? Okay, so we're talking about an artificial endothelial lamellar, so-called DMEG lamella here. And I would like to introduce that topic to you. I work together with a lot of companies, also the company that produces this. This is not an approved device, but in studies. So we receive research grants from them. And as you heard, the topic here is I can't wait to get this innovation into my hands. I had it already in my hands, so to say, but we have the very first results. So I like to share with that. And after I showed you some of the results, I will go to these 4 questions, how this has excited me or changed the life. So I think I will do it this way and not answering first the question. So the problem that we're facing is, a couple of years ago it was different, but if I look in Germany at the moment, around 70% of corneal transplants are actually DMEC procedures. Yeah, we're doing rarely, so to say, perforating keratoplasty. There are, of course, indication, but not so often anymore compared to previous times. In Germany, around 8,000 to 10,000 corneal transplants are done. And the funny thing is, over the years, the waiting list has not really become smaller because we have a bigger profile now of patients. So we do surgery earlier in Fuchs endothelial dystrophy. We have patients after phaco that have a decompensated cornea, and the number of patients increases. And the number of patients, for example, for keratoconus decreases because we have other treatment modalities like cross-linking and so on. And so there is still an issue in terms of shortage of implants or transplants. And if we would be able to have an artificial DMEC layer, not a whole artificial cornea, the artificial DMEC, it already would help us. If it's temporarily or permanently, if it will just decrease the thickness of the cornea, and then we can do later a human layer. There are a lot of things we can discuss, and I will first describe you how we use this in the first patients. So what we essentially have here is the product called EndoArt by an Israeli company. There are other doctors from our field involved also in working on this, like Ofne Daphner or Dr. Markovic. And what we actually have is a kind of, looks like a contact lens, which you put inside the cornea instead onside the cornea. It's like 6 millimeter in diameter, dome shaped, as you see it here on the picture. And it's made from contact mark copolymer, hydrophilic acrylic. So that's the same material we use from contact mark for our hydrophilic acrylic intraocular lenses. So it's a material that has been proven over years to be stable, biocompatible. And so there's not really an issue about the type of material we're using here. So the first 2 patients I put it in were kind of desperate patients, and it was not about getting good vision. It was about, can they tolerate it, and do we have a kind of proof of concept? So this patient here, number 1, 58 years, had an externally phaco IOL implantation years ago, but unfortunately had an endophthalmitis with a postplantar vitrectomy with consequent other problems like a corneal decompensation, optic atrophy, then got a DMEC, multiple rebubbling, and at the end she ended up bullous keratopathy, and she didn't want another human transplant or something. But I could talk her into using this because she had a lot of pain because of a bullous keratopathy. You see here the OCT with the 730 micron thick cornea. And I hope this video is running. Is it running? Yeah, somebody is knocking his head. Very good. Thank you, Michael. So we don't had a real regime how to implant this. So I used the conventional IOL inserter and implanted this into the eye, as you can see here. And it comes out in a second. First, what you see is, I think that's just an air bubble. Don't worry, that's not the implant. And now the implant is coming out, unfolding there. And we all know how delicate the human tissue normally is if we have that in the eye. But with this kind of device, you can just touch the lens, so to say, with your spatula like here and position it under the cornea. So something you would never ever do with the DMEC lamella. And then I did this here with the syringe and with the needle. I can directly put some air under it, then position it. And I checked actually here with the intraoperative OCT, and I don't know if you can see here, this is the implant very nicely already on the inner surface of the endothelium. You can also see this has a little angle here, and you can see that this is the right positioning. If it would be the other way around, it would have been flipped around. So we can see very nicely that we put it on the right place. We also see here the thick epithelium from the long long-term bullous epithelial keratopathy. And we don't really think that we need a strong filling of the anterior chamber with gas and air. We did it the same way we did the DMAC, but we have now learned that just the pressurization and keeping it for 10 minutes like this, and then you can remove the air, would be sufficient for enough adhesion. But at this time, we did it this way because we were still learning how to proceed. So I think this is quite clear, and you can see here the implant. Now let's go further. So, oops, that was too fast. So this was pre-op. This was already the very first day, and you already can see that the cornea becomes clearer, especially here in the center. Because of the bad epithelium, I put a contact bandage lens over it. But you see here, nice placement, cornea already down to 593 micron, very first day. So this looks good. Then we went further on. This is after 3 days. After 2 weeks, we had already a normal cornea of around 500 micron, and it stays like this. Now we have 1 year follow-up. We had some issues in between. I had to reposition it. I will talk about that later. But you could already see that this blocks the water from coming in. Let me show you the second patient quickly, which had a similar history, failed phaco, failed DMAC, and also bullous keratopathy, even some scarring here in the epithelium. We did the same surgery. I don't show you the video due to time constraints. Here you can see first day post-op, you see that he had a very bad epithelium also, but already after 1 day, it went down with the thickness of the cornea. We had some repositioning, and we could see that the cornea became thicker after 24 days, but this was done fairly easy, just under, with the syringe. We went in there and the spatula and positioned it, and it was everything we had to do. And here you see after 6 months, a very nice anterior view where you can see that the implant has integrated very nicely. Cornea has normal thickness. Outside the implant, it is a little bit thicker, but here the center is very nice. And just today I saw him for the almost 1 year follow-up, and it's exactly the same picture, so I don't need to show you that. Here you see we had some repositioning, but we ended up in this zone here around 500 micron. And as I said, we did the surgery in June and July last year, and we are now almost at 1 year with very good results. So we had successful implantation and decreased corneal thickness and improvement of clarity. There is an international study going on. Here are the first studies from Israel and Netherlands. They had also 4 implants, which look quite good. And if we look at the average reduction of corneal thickness, we are around like 25%. So here from around 800 to 500 something. But the other cases are not so long on the run. So why does it excite me? Well, because first of all, it works. Yeah, we have we can do that very simple treatment. It's not really complicated surgery. We can do that. It's good material that is biocompatible. Corneal thickness came back to normal. These patients had no pain, irritation anymore. We don't really expect an immunological reaction, not more than we would expect from a hydrophilic intraocular lens. And even if we have some problems, repositioning or other handling is pretty easy to do. It will change the life of the clinicians in terms of that we have an alternative to human tissue. Very easy or not so difficult to learn a surgical procedure. We don't really need a waiting list for that, because if a patient has a corneal decompensation, we can put it in, and maybe even later do a procedure with a human cornea. So this is also quite nice. For the patient, of course, he has also the advantage that he has no immunological reaction. I don't even know if we need, apart from a perioperative steroid treatment, anything more than that. A reduction of corneal edema means no bullous keratopathy, means no pain, no irritation. The costs are lower, less traumatic surgery. I think it can be evenly done in ambulatory day case scenario, but we will see that. And we can also pre-treat a complicated case by decreasing corneal thickness, and then even later do a normal DMAC. It's also possible. So there's a lot of things we can discuss about, and it solves a couple of problems. No human tissue, but with an artificial treatment, we have that. And there are a lot of countries where it is not so easy to access human tissue like it is in Germany or maybe in the US, where you can just order it from iBanking. If it's a temporary implant or even a long-term implant, we will see. My patients now have 1 year follow-up and it's still good. So this is very, very good. But maybe on the long run, we can even exchanges, or we can use it with some refractive component. So also correct some refractive error or astigmatism with it. I think there's a lot of potential in that idea. And I'm glad that the basic system is working and that we can see here at least a proof of concept, and the multi-center trial will give us a lot of more insight. So thank you very much, and you can understand, I guess, why I was so excited about this implant.
Thank you so much, Gerd. It was really excellent talk. So at the moment, I have a lot of questions in my mind. I am sure we need very long time to discuss. Very exciting technology, very exciting method. Now, unfortunately, limited time we will discuss after Soosan presentation. Now, Soosan Jacob will talk about very nice, very good, very exciting treatment alternative. Recently, she developed wonderful methods. I'm really very interested about this personally. I really look forward to listen to Soosan talk. Thank you so much, Soosan.
Thank you, Aylin. Can you hear me?
Yes.
All right. Thank you so much, Aylin, Christine, and Michael, for inviting me here. This, I think, is going to be a really look forward to session. This and all the future ones that you're going to be showing. I, for one, find this whole concept that you've created very, very exciting, and I'm definitely going to be watching each of these webinars. I'm going to be starting off with my topic, which is basically CARES, and this is an acronym that I created for a technique that I call as Corneal Allogenic Intrastromal Ring Segments, CAIRS. I must say that I do have a patent pending for special trephine's devices and process to create these segments, as well as for CARES and various types of shaped corneal segments. The need for this procedure, we must understand that the prevalence of keratoconus, which was originally thought to be about 1 in 2,000, with recent studies is shown to be much more. In a study on the prevalence in pediatric patients in Riyadh in Saudi Arabia, it was shown to be as high as 1 in 21%. And generally now it's taken as 1 in 200 patients have some kind of subtle abnormal findings which need further investigation. So keratoconus is really becoming a much more commonly seen procedure. So seen disease, basically also because of much better investigative modalities that are now available to screen patients for. The current treatment, of course, is cross-linking, and cross-linking is a very good treatment, but by itself, it has a limited role in regularizing corneal topography or in improving vision. So, you know, this, if it can be combined with a technique that can also improve the patient for vision for patients, it would be the ideal situation. Intracorneal ring segments have, of course, already been tried and are being used for this in the form of Intacs, Kera rings, Ferrara rings, Mayo rings, and so on and so forth. But all of these are made of PMMA or plastic, and though they are effective in improving the quality of vision, they can be associated with complications as seen in this. This is my own series of patients, all the photographs, which you can see the migration, the overriding of the segments, the extrusions and the melts that can happen with the overlying corneal necrosis and melt. You can have intrusions, which has even been reported in literature to cause acute eye drops years later. You can have infectious keratitis, which can even lead on to the need for a therapeutic keratoplasty. And up to a 30% rate of complications can occur with synthetic implants, especially if you're not very careful about the thickness of the corneas that you're going to be implanting on, or the type of keratoconus that you're implanting on. So here is the technique that I'd like to share with you today. And this is basically the CARE segment. And you can see that that's the trephine that I've designed for making these segments. These segments are made from human donor corneoscleral rims. And I'm going to show you this video as to how to prepare this. This is a donor corneoscleral rim which has been mounted on an artificial anterior chamber. And the first thing you do is remove all the epithelium from the rim and remove all the endothelium. Here's a special trephine that I have devised, which has 2 concentric rings, as you can see. Just go back a bit. It has two concentric rings, one within the other, and you use this to punch out a ring of corneal tissue. Now, this corneal tissue is pure stroma because you've removed all the epithelium and the endothelium, and you get this ring, which is then cut further into two segments. These are simple cataract instruments that I've modified to be able to implant these segments in. The femtosecond laser dissected channels have already been created in this patient's eye, and now I'm implanting these segments, and you can see that it goes in very easily. I've got entry incisions on both sides, and so I can use a combination of pushing in and or sliding it in and then drawing it in from the other side further using a reverse Sensky. And in patients who are progressive or younger patients who are showing signs of progression, I always combine it also with cross-linking. Here's a post-op, I'm sorry about that. Here's a post-operative video showing the scare segment in situ, and I implant these segments at 50% depth. So you can see it's a very quiet eye, 50% depth as compared to the much deeper depth that is required post synthetic segments, where you need to put it at about 80% in order to decrease the risk of extrusion and melt. You can see the two segments there, a superior and an inferior segment, lying very quiet and hardly visible. So what are the disadvantages again of synthetic implants? It's not just the complications, but also the fact that you cannot implant them in very thin or very steep corneas that are beyond a certain limit. Also, the effect that you get can be limited because you have to implant it by force deep in the cornea to avoid complications. Unlike this, CARES can be implanted in advanced cases, so there's no limit to the amount of thinning. You can implant it in extremely thin corneas also because there's no risk of overlying melts or necrosis. We know that in DALT, you're actually implanting the entire cornea onto just a bed of Descemet's membrane, pre-Descemet's layer and endothelium. So obviously this CARES can also be implanted in advanced cases, and I have done it up to 80 diopters of Kmax. You can also implant it, the advantages in mild and early cases, you can implant it at 50% depth or even more superficial if you want to, so you can get a greater effect, though I prefer 50% depth. And you can also implant arc segments up to 360 degrees very easily, unlike say, in PMMA, where it's much more difficult to take big arc segments around. So you get a much wider pool of patients where this can be used, right from mild to advanced cases. You can do it in simultaneous with cross-linking. You can implant it in patients who have already undergone cross-linking, and you can also implant it in patients with no documented progression to improve vision. You can also put in keratoglobus, PMD, post-classic ectasia, etc. And the best part is you can also use it to treat MELS, migration, extrusion, etc., which are complications related to synthetic segments. So here you can see a segment with overlying melt. This is an intact segment, and this is how the CARES segment looks in comparison. You can see very quiet. So this is a video I'd like to share with you, which shows this synthetic segment melt that I'm going to treat with a CARES segment. It's an interesting video, but for the sake of time, I'm going to run through it. That's the area of melt, and you'll see the area of melt is generally larger than what you think clinically because there's this epithelium that's covering a lot of the area. And so what I've done is I've just pulled this synthetic segment out, and I cut the CARES segment into the desired length and thickness. And I put these anchoring sutures on either side, anchoring the segment to the cornea, and bridging sutures which basically go over the CARES segment but not through, just to hold it in place in the post-operative period. And here's the post-op appearance. You can see this is before suture removal. This is 3 months later, and you can see this patient with a synthetic segment on one side and a CARES segment on the other side. So this is a beautiful way of treating these patients. Here's a topography which shows a tomography ASOCT, which shows very well-placed segments. You can see that the posterior curvature is increased, anterior which is flattened, to an improvement in the spherical equivalent, which means that the refractive error also comes down. We've seen that all these patients have improvement in almost all parameters. The way it acts is, of course, by Baraka's thickness law, which means that when you add thickness to the center flattens. Now, in our results, we saw that it flattens the steep cornea, regularizes the topography, centralizes the cone. It decreases the aberration as both the spherical equivalent is decreased. It also decreases, of course, by default, the dependence of the patient on contact lenses for clear vision. The best part is it spares the visual axis like other additive procedures like ICRS. It's reversible, replaceable, and adjustable. I'm just going to share with you some of the results here, post-operative topographies, and you can see a huge amount of regularization of the corneal topography. The vision improved from 624 part to 69 part, and a great decrease in the cylinder. Some other topographies, patient with a high cylinder of 5 diopters, which is flattened out quite a bit here, and you can see the difference map showing the great amount of improvement in the cylinder with shorter arc segments that were used. Here's a preoperative picture of a patient who's got a steepening, inferior steepening, and I've put a single segment for this decentered cone, and you can see postoperatively the flattening that's also seen in the difference map, giving you very good results. Again, an asymmetric segment, just single segment placed below for an inferiorly decentered cone. You can see up to 15 diopters of flattening here. Lots of similar results. Here's a patient, very interesting patient, who's, if you can see here, got 2120 uncorrected, postoperatively improved to 2030, and you can see the differential flattening that's brought about, more flattening in the steeper areas and less flattening in the less steep areas, which is ideal, and which is what we would like to have. The cylinders drop from 7 to 2.5 diopters, and you can see the thicker segments that are here. The other eye, we didn't need as much as effect, so we placed thinner segments, and you can see correspondingly we have managed to get a lesser effect as we would desire. The cylinder, the pre-op spherically, the sphere refraction improved from -1, -1.25 cylinder to 0.5, 0.5 cylinder. So you can get excellent results depending on how you're tailoring the segments. Again, a patient with one eye, cares and cross-linking, and you can see the lot of flattening that's happened. The other only cross-linking was done because of financial constraints, and you can see that there's not just cross-linking, and there's a beautiful comparison which shows the additional effect of cares on these patients. You can also do this in very steep corneas. You can see this patient's about 67, 68 diopters, 72 diopters actually steepest, which is dropped down to 59, and we avoided DALC in these patients. There's another patient where we've got about 20 diopter flattening, very steep cornea. Again, in this patient, we avoided DALC. So you can see these procedures can be done for all the entire gamut of keratoconus from mild to severe. Again, ASOST showing very quiet eyes. We've done more than 140 patients so far, and we published our results in JRS, the initial results. You can also get insurance for this, and we're doing that in our country, but also in US and other countries, you can also process it as a lamellar graft, and therefore that has the additional advantage. And to conclude, I'd like to say that this is allogenic tissue, so it doesn't have disadvantages of synthetic tissue. In addition, it has good corneal integration, less complications. It's easily available, at least in our country, and it's easy to perform. It's effective, stable, simple, safe, reversible, adjustable, and it's got a very low level of rejection. And I can go through that later, but for reasons of time, I'm going to stop now. The reason why the level of rejection is very low. And with that, I'll come to the end of my talk. I think, Aylin, you've also done CARES yourself, and also it's being done in many countries now, including US. And I'll be happy to help anyone who would be interested in doing this technique or starting this technique. The Trifines are manufactured by a company in India, and I'd be happy to put you in touch with them. Thank you so much.
Soosan, thank you so much. It was really wonderful. I performed this technique, and outcome is really very good, very parallel. And I have only a very quick question with time pressure. What did you change? Normal intact, we were using intracorneal material, PMMA. And what was the change when you perform allogenic corneal ring about nomogram? For example, larger channel or deeper or thicker segment? What was the big change when you perform this surgery about your nomogram?
I think the difference that we got was one is we could put it at 50% thickness, 50% depth, so we could come more superficial, and also we could get a wide variety of thicknesses that we can put, which gives you immediate adaptability on the table. So with all the segments, you are constrained by the sizes. You have to have a large inventory of all of these, which is not the case here. You can change in terms of nomogram, you can change the arc length, you can change the optic zone, you can change the thickness of the segment, and you can change the depth at which it is placed. You can also have variable thicknesses with asymmetric segments created as if you do an intact, and you can also have the same segment made in an asymmetric way, which means one part of the segment is thicker and the other part of the segment is thinner. So there's a lot of variation that you can do with this technique.
Mm-hmm. Within time, did you observe any change, progression or regression, or a change in topography or refraction during follow-up?
Good question, Aylin. In almost all the patients, we also do cross-linking because CARES as such is not going to stop progression. It's for decreasing, it's for improving the topography. It may have some additional effect in decreasing progression by just redistributing the corneal stress forces, but the major effect of decreasing progression is going to come from cross-linking. So CARES is not to be used as a technique for stopping progression, but rather in adjunction with cross-linking in young patients. In patients who are older and who have already been cross-linked, of course, you can use CARES just for visual improvement.
Thank you so much, Susan. I have a lot of questions. I learned so many things from you. Thank you to share your experience with us.
Okay, so Gerd, I have a couple of questions for you.
Yes.
Fascinating talk, wonderful pathway. Let me start, and my first question actually addressing what Susan has done. She went from using intrastromal rings made of plastic or artificial materials or hydrogels as intrastromal rings towards back to tissue.
Yes.
Your approach is moving from tissue back to new advanced materials. So my question is, the learnings we had with, I like to say, Cindy Roberts always said the cornea is not a piece of plastic, so why we're putting in plastic? So now you're adding in a hydrogel again. Do you expect something on a long-term situation we know from intrastromal rings or other cornea implants like used in presbyopia, or are we here in a different ball game?
Yeah, we are at a completely different ball game because we are not putting anything into the tissue. We attach it to the tissue. Yeah, so we have attached contact lenses to the outside of the cornea for decades. We have put in same hydrophilic material inside the capsular bag for decades, and we are not going into the tissue. I mean, and we are not propagating that we make an incision and put it under the Descemet or a Bowman or wherever. We really leave it as an adhesive implant onto that, and we just blocking the amount of water floating inside. So we are not inside the tissue. We know from other intrastromal implants that we can have reactions or haze or any kind of stuff, but we are not inside the cornea here. I'm not even talking about a permanent implant. We are still very much surprised that after 1 year, it still works. Yeah. So time will tell and studies will tell. But the basic difference is if you go inside the cornea, like Susan did, maybe this is more advantageous. And if you are outside the cornea and you don't have the availability of human tissue, maybe then the plastic could be interesting.
So you mentioned that there's adhesion happening. Are you removing first the original recip endothelium, or do you leave that endothelium intact and put it just as a layer on top?
Yeah. In these two cases, we didn't remove the endothelium. We left it in. The epithelium, endothelium here was diseased. It was not good. Yeah, it was already compromised. But I didn't want to have an additional trauma by scraping it off. It may be an advantage to do that, to have better adhesion, but I'm not worried about the adhesion at the moment. We will see that in our multi-center trial. Especially, I had corneas who were extremely thick and distorted and had big bullous keratopathy. If we're talking about a kind of planned DMEC procedure in an eye which is not so much compromised like these severe cases, we may discuss about removing the tissue. So this is, as we said, it's very new stuff which leaves more questions than answers, but yeah, that's why we do these studies.
Maybe briefly, with those two patients, did they experience significant vision improvement, or?
The two patients that I was presenting had already compromised vision because of optic atrophy and stuff like this. Yeah, but both the second guy, he had improvement of 2 or 3 lines, which was quite nice. But I'm still working on his epithelium because it was he had some scars under the epithelium. So I'm looking for a solution there. But he is improving quite good in vision. The other lady has just a very small field, visual field. She said she has a subjective improvement in terms of visual field because she can drive car much better because it's clearer on this side. She went from a light perception to some 120 in 1 meter. She could see the biggest sign, so a little bit she could see. But that was not the intention in these more or less very first 2 patients. In the big multi-center trial, we will go more onto the detail in terms of vision improvement.
Wonderful. Very fascinating technology. Thank you very much to both speakers. Very exciting and you know, taking the opportunity to sharing that with us. Thanks a lot.
You're welcome.
Aylin, we're moving on.
Oh, Michael, Sheraz has a question.
Sorry,
for
Sheraz.
Gerd.
Well, this for Gerd. That was a very nice presentation, Gerd. I've seen a bit of that before. Just after a year, have you noticed any, because plastic and cornea sometimes don't go well with each other in terms of reaction. I know it's not within the cornea, it's seeding the cornea. But is there any interaction? Have you observed any scatter? Have you used anything to measure scatter at the host polymer interface?
Yes, no, we haven't. But I can understand what you relate to, especially if we think about other hydrophilic implants that cause it even material degeneration. We didn't have anything like this here. A lot of things that we didn't show in the presentation were work that has been done in the animals before. So sizing is an issue. If you have a too big implant, 8-9 millimeters, it may really interfere with the nutrition of the cornea and can lead to problems. They saw that in the pig eyes, yeah. And the 6 millimeter size is the optimal size we could find for having a good adhesion, having a clear cornea, but have not a completely thinned cornea or something like this. So there are issues, but there are not material-related issues at this moment.
So in the same way you've got an impediment of fluid going in, you also have an impedance of nutrients going into the cornea as well. And that's been the experience with inlays in the past, like the polysulfone inlays and others that were used inside the cornea, admittedly, but they still affected nutrition. And eventually you had corneal meltdowns and scarring and so on. So I just wonder if the same mechanism is in place, or is it small enough to avoid?
Yeah, I think it's small enough. I think it's a hydrophilic acrylic, so there is some fluid going through. Yeah, we are not having. They first tried actually silicone materials. Yeah, because if you see sometimes silicone oil being adhered to the cornea, for some time it can block the water and the cornea is clear. On the long run, it kills the cornea. But so that was the first intention, to use silicone material, then hydrophobic, then now hydrophilic, and this is the product that seems to be quite good now.
Great, thank you.
You're welcome.
Next speaker is Richard Packard. He's from London, very experienced surgeon. Recently, he celebrated 50 years in ophthalmology, right, Richard? And now,
doctor.
So now he will talk about capsule laser today. This is innovative cataract surgery about capsular access. Now we will listen him.
Aylin, thank you very much. Thank you for asking me to be part of this. Oh. Microsoft has just asked me to say I have an account problem. I'm not quite sure why. Anyway, let's see if we can manage to do this. Right, here we go. So I thank you very much for asking me to be part of this team to talk about oracles of eye innovation. I've been involved with capsule laser for quite a few years now, and I think the use of this device, which creates a selective laser capsulotomy, is a better way to open the anterior capsule. Much as we may believe that the President of the United States says of us, this is a wonderful mug that I found, which says you're the best eye surgeon in the history of eye surgery, maybe ever, very special, very skilled, that I can tell you, just terrific. Believe me, you're great. Everyone agrees. If you disagree, that's fake news. Well, okay, maybe. Anyway, what is the problem? that selective laser capsulotomy can solve. We cannot consistently deliver our goal manually. That is to create the chosen size, the perfect circle, and the desired centration of our capsulotomies. We often end up with something that looks a bit like this, especially a year or two down the road. Now, why did it not move? This is very strange. Try again. Okay, so why does this actually matter? Well, we know that 360-degree coverage reduces the risk of early PCO because the lens optic gets shrink wrapped. If you have a well-centered capsulotomy, it gives better IOL centration, and there is less axial deviation refractive change, which is particularly important with premium lenses like multifocals. And also we know that a capsulotomy, if it's too small or too large, can impact on our nuclear removal technology. And there are lots of papers that you can look at, many more than this, which will give you an insight into that. Here we can see some pictures from David Spalton showing what the importance of 360-degree coverage is. This is a capsulotomy which is off the edge of the optic at 1 year, and you can see there is extensive Allogenic pearl formation. Here we can see one that is beautifully centered with the lens fully covered by the capsulotomy, and at 3 years, there's no sign of PCO at all. How can we try and achieve this goal in some other ways? Well, you could use a capsulotomy ring like Marie-Josée Tassignon or a corneal marker, or you could use some device like Verion, which gives you a head-up display in the microscope, or you could use precision pulse capsulotomy, which I know that Vance is going to be talking about, or the femto laser capsulotomy. I think a better way of doing this is selective laser capsulotomy, and I know Sheraz has some experience with this. So why would you want to use a laser for the capsulotomy? Because they can make capsulotomies of a given size, which are truly circular, without the variables of the manual technique, and in a position which is given that you want to choose, which can be particularly useful for more complex eyes. And also because there's then little risk of tear out during the capsulotomy itself. And we know that this can then be useful in intumescent and white cataracts. A capsule laser creates a selective laser capsulotomy, which is much lower in the capital cost than femto. There is a low cost per case. There's no disruption of the surgical flow. It uses minimal space in the operating room, and it gives you consistent accuracy of sizing, circularity, and centration. How does it actually work? Well, the laser is not pulsed, it's continuous. It operates through the absorption of the orange wavelength of 590 nanometers of laser energy onto a trypan blue stained capsule. And this changes the type 4 collagen to amorphous collagen. As the collagen undergoes this phase change, it creates the capsulotomy with a rim that has a high degree of elasticity and strength, which is associated with amorphous collagen. And it is scanned in a single circular pattern to create the continuous curvilinear capsulotomy. Come on, move. Here we can see the device underneath the operating microscope. The console is very small and it fits on a tray on the microscope. This is the control module, and you can set the size that you want. It's all very simple as far as the electronics are concerned. The user interface allows you to set a diameter between 4.5 and 5.5 in 0.1 millimeter increments, and there's a reticle intensity and also warning indicators to give you safety for the surgeon and the patient. And there are also laser sources within this. Here we're going to see a video of the trypan blue. This is a different solution from what you're used to. It's microfiltered, it's a little bit more concentrated. And because it is heavier than water, it sinks onto the capsule. It then needs to be washed out with the BSS. The eye is then filled with an optically clear 2% sodium hyaluronate. And you want to overfill the eye till you have the viscoelastic coming out of the side port. You then turn on the aiming device. You can see over here that this is now properly focused. HPMC is applied to the cornea to give a good contact with the patient interface, which is then applied. So the video seems to have stopped. Not quite sure why. Click onto. Okay, so let's start it again. Here we can see the patient interface in place, and the laser is fired, and the capsulotomy created in 0.3 of a second. Has this laser been investigated? Yes, certainly. There were preliminary preclinical studies which utilized 2,500 porcine eyes and 150 cadaver eyes, and this was carried out in Singapore, the Singapore National Eye Center. And comparisons were done between manual femtocataract and capsular laser capsulotomy. If you look at the edge, you can see it's very smooth. And over here, you'll see where the amorphous collagen is all the way around. The edge is very strong. Sheraz reported a study which was done on paired cadaver eyes comparing CCC femtosecond laser capsulotomy and capsular laser was 150%. And this was reported.
Hello?
Right, an author here.
Richard, can you hear us? We cannot hear you. Okay. I think there is this communication. There is he doesn't look like online. We can continue, and I wouldn't like to stop, and now we will continue with next speaker. I would like to introduce now Sheraz Daya. He's from London after capsule laser. Sheraz developed a very nice method, transmacular hydrodissection. This is innovative method to reduce ultrasonic energy. He performed more than 6,000 cases. Now he will introduce us about this technology.
Great, thank you, Aylin. Let me just see if I can get online here. Am I in the right place? Share. So I'm using two screens. I just want to be sure I'm on the right screen there.
It's
Can you
good.
see that screen?
Yeah.
Can you see it? Can you see it okay? Hello?
No,
We cannot see you.
Richard has to stop his screen sharing.
Am I not sharing my screen at the moment?
But I think Richard is interfering. Now you're. Yeah.
No, I am. Sorry.
Oh, now we can see you, but now you have
Can
to
you hear
share
me?
your screen.
Okay, so escape.
Share your screen again.
Yeah, I'm going to do that. So let's do that. Share
Can you
screen.
hear me? No, my internet's gone down, I'm afraid. No.
Here we go.
Yeah, got it?
Yeah.
Very good, very good.
Yes. Can you see that? Am I on the right-
Perfect.
Is that the correct screen? Hello, can you
see
hear me?
It's
No.
your screen, your presentation.
Yeah, we can see
Shiraz,
your, well, we're seeing the speaker view, Shiraz.
Now it's
There you
good.
go. Now you got the right one.
But can you
Yeah,
see that?
you're good.
Yep.
Yep, we're good.
All right, great. Well, thank you very much for inviting me to this Oracle's, your initial one. I'm very flattered. And when I was asked what to talk about, I thought, well, innovation comes about from a variety of different directions. And I thought I'd talk about mine because firstly, it's very simple and straightforward. This is my financial interest. I work with Bausch & Lomb as a monitor for their lasers, and I'm going to be discussing femtosecond laser cataract surgery. I thought the Oracle's concept was a really good one because this is a way to illustrate how innovation comes about. It can be through new technology, which we've heard about today. It opens new doors. An example would be computer processing power. When that increases, our ability to do things increases, and we've got now the advent of machine learning and artificial intelligence. That's probably the next new thing. Sometimes technology elsewhere can result in cross-fertilization to another area. So the XML laser is a classic example of that. It was used in industry, and then people went and investigated, figured this could be used for eye surgery as well, and that you can see the results of that. And then sometimes there are things that happen quite by accident, and this is my story. So we just heard about capsule laser, which is a great technique with a manual capsulorhexis has really revolutionized cataract surgery. And we have the femtosecond laser, which is a bit expensive, but actually it's not that bad if you do it on everybody. The economic argument is a different one altogether. But in all these types of operations, there are challenges. And this is the one that was described by Roberts and company, and there were others that didn't want to really talk about the food poisoning cases, like McDonald's talking about the food poisoning cases. They didn't want to talk about the lenses that got deep sixed in the first few cases of femtosecond cataract surgery. And there's a reason for why this happened. And this is when patients were conventional. This is another problem we have. We take our reference points, we move them on to new technology, but actually we have to revolutionize what we do. And doing conventional hydrodissection in femtosecond laser cataract surgery can be quite hazardous, as they discovered. And they had lenses that went into the vitreous soon after hydrodissection. There's a reason for this. If you look at Miyake's original paper from 1998, he described capsular block syndrome, where if you inject fluid, hydrodissection, you can sometimes get capsular block and distension of the posterior capsule. It goes into the next phase where the anterior capsule widens, and it can eventually tear. You can get a radial tear, or at worst, you can get a posterior capsular rupture, and the lens falls into the back of the eye. Well, this is exactly what was happening with femtosecond laser cataract surgery when they hydrodissected. So when we're lasering the capsule, there is, by the second law of thermodynamics, there's going to be some heat generated. And when heat is generated, you get fusion of cortex to the anterior capsule. So this is me doing one of my first 9 cases. And I'm doing exactly what everybody else is doing, making the same mistakes. And you can see the anterior capsule widen. Well, that was really frightening. And that lens was rigidly in the eye. When I did this sort of rock and roll technique that I learned from doing extracapsular days of dissecting that lens by rocking it. And that seemed to relieve things a little bit. Well, I resolved not to do that. The first 9 cases, I had 3 anterior capsular tears from doing this maneuver. I didn't have any deep 6 nuclei. But what I said was, yeah, I'm not going to do that anymore. What I'll do is break up the lens, take out the first piece by shoehorning it, and then continue there. So this is an animation of what takes place. You got fluid going in, it distends, it goes around the other side and stops, and the posterior capsule keeps distending. So here I am. This is where I learned something by accident. I'm taking out that anterior capsule after doing capsulotomy and fragmentation, and here I'm using this hydrosection cannula, and I'm using that to break up the lens because I want to break that up and take that first piece out. And by mistake, I injected fluid. You see that bubble started moving. This is the actual case where this happened. And that's interesting. Now, if I did that by mistake, look, the lens is moving. Wow. I hydrodissected through the lens without doing it by intention. So I said, well, I wonder if this can happen every time I do this. So I actually tried it over and over again with the same cannula, and it worked. So, well, actually, this cannula is not designed for this particular purpose. So working with Mrochen, we designed this translenticular hydrodissection cannula, which is a bit like a phaco chopper, which has got an irrigation port on the end of it. Now, people find it scary, but I don't know why they find it scary. It's only 1.5 millimeters long. The lens, as we know, is between 4.5 and 5 millimeters at its greatest depth. So, you know, being careful, you can do this in every single case, even hard lenses where the peripheral nucleus is soft. You just don't have to go in as deep. But here I'm just, for exaggeration, showing how this little cannula can be used to complete your phaco chop and make surgery a lot easier and take out each fragment at a time. So this is an animation illustrating the process. So here we're injecting fluid. It displaces that air bubble. And if fluid fills up the capsular bag, it comes out through the actual lens fragmentation, as it does not need to try and go out the other way like it does with conventional hydrodissection. So we decided to study this. You know, does it make any difference? Does it make any difference in terms of ultrasound time, average power, and effective phaco time? And what we did was we compared my previous 108 cases of traditional cataract surgery using a manual capsular access to femtosecond laser cataract surgery without translenticular hydrodissection, shoehorning, in other words. And what we found was there was a reduction in average power and ultrasound time and EPT, and it was statistically significant. And then what we did was took our first 108 translenticular hydrodissection cases and compared them to their first 108 done without. And again, we found there was a significant reduction in effective phaco time and ultrasound time and power as well. And you can see this is pretty respectable of 0.52 EPT in those cases. And we published this in JCRS, and we got some contentious responses from a couple of Australians, which we responded to appropriately. This is just to show using that cannula. The lens is now out after translenticular hydrodissection. A lot of people talk about sticky cortices. Well, here's a great way of removing cortex very, very quickly by doing cortical cleavage after the lens nucleus has been removed. So laser capsulotomies, where we do 100% femtosecond laser cataract surgery, and we're now using capsule laser as well. We find that generally this whole technique is reproducible. It assists lens dismantling, there's less zonular stress, reduces ultrasound APT. And you know, I think that the value of fragmentation is probably underestimated, especially in harder lenses. And there are many newer studies showing a reduction in posterior capsular rupture rates. And we have found that ourselves, and it's something that we probably should publish. So looking at what does innovation excite me? Well, it just makes everything reproducible and easier. Yeah, how does it change the life of clinicians? Well, I've just answered that question too. And does it change the life of patients? Well, it makes time in surgery less. There's less stress on zonules, less time in the eye. It can only be good for them. And does it solve a problem? Yes, it solves the problem of deep sixing nuclei and hydrodissection in patients undergoing femtosecond laser assisted cataract surgery. Thank you for your attention.
Sheraz, thank you so much. It was really wonderful study. I am sure very helpful for cataract surgeons. And we will receive questions about end of this session. I'm sure there are questions. Thank you so much. Wonderful. Now I would like to introduce next speaker, Vance Thompson. Vance Thompson is only speaker from US. Thank you so much, Vance. We are different time zones. You accepted to join us between your surgeries, I think. Thank you so much. Now we listen you about precise centralization with Zepto device. I look forward to hear your presentation.
Thank you. Thank you. And it's been so wonderful hearing all the other speakers also. And Dr. Packard, I was just loving your presentation on capsulorhexis and the capsular laser. And Sheraz, great job. You were the two speakers that I heard because I was in surgery. And thank you for having me. We're going to talk about the development of the Zepto technology. And a little bit more about the capsulorhexis. You can tell that it's a very important topic when all that's being dedicated in the research. And I have been involved with menosis, now called centricity, from its beginning. And as you can tell from some of the other talks, that the importance of the capsulorhexis, we want it to be perfect in size, shape, and its location for centration. And there's a number of ways to achieve it, but the proof of principle of using a nitinol ring started about a decade ago, and it led to an NIH grant that led to the early development of the Zepto technology that involved a nitinol ring housed in a silicone home to be used to perform the capsulotomy. And it led to the evolving of a number of tips from early on the left to later on the right. And the early Zepto system was first used on rabbits at the Mrochen Eye Institute by Dr. Werner and Dr. Mamelis, and led to some great results. And the first human Zeptos were performed by Dr. Kevin Waltz and myself in El Salvador. And this is my actual very, very first Zepto procedure, and it went beautiful. I'll show some more videos here in a little bit. But we took our desires to the FDA after developing a protocol, and had a great meeting, and proceeded to have a clinical trial that went very well. And the current handpiece, now FDA approved, involves a rather sophisticated little silicone suction cup with a nitinol ring of 4.4 millimeters in diameter that leads to a capsulorhexis diameter of around 5.2 millimeters, all driven by this console. And I like how it fits right into surgery on my surgical tray. Dr. Packard talked about some of this also, but we know that the lens epithelial cells, as far as the germinative zone, are out near the equator, right under the anterior capsule. And what we want to try to do is prevent that anterior capsule from fusing to the posterior capsule. So overlap of the capsule, like Dr. Packard said, is so important, because if we don't get it, that anterior capsule leaflet can fuse, and the sequence of events that happens in the capsular bag for fibrosis and contraction can lead to tilt and decentration of our optic, and reduction, of course, in image quality and glare and dysphotopsias. And this has been studied beautifully in the past by people such as Dr. Apple, and he described a less aggressive PCO, that is our goal, versus a fibrotic, aggressive PCO that we want to really try to prevent. And a number of great researchers said the same exact thing, that apposition of the anterior capsule edge to the posterior capsule is dangerous with regards to what it does to capsular fibrosis. And anterior capsule is dangerous, leading to that fibrotic type PCO. And so many people have talked about it. So how do we prevent this? Because in this publication by Carlson, just a little bit of apposition of the anterior capsule to the posterior capsule leads to a progressive zippering and a progressive decentration of the implant over time. We really, really want to do our best to prevent this in surgery. And we've all seen it for 360 degrees. I like to call it capsular fusion syndrome. And so as far as our goal, it's 360 degrees of overlap of that peripheral optic. And there's a number of great ways to do it. The capsular laser that Dr. Packard talked about, femto that Sheraz talked about, and for you femtosurgeons, you really want to center on an OCT guided image of the lens. You don't want to center on the pupil. You want to center on the lens. But how do we do it manually? And how do we do it with something like Zepto? Well, it involves using some reflections that are in every surgery there to help us. Specular reflection is a mirror-like reflection off of surfaces that happens beautifully in the eye. They're called catoptric images, and they were first described by Dr. Purkinje, a Czech anatomist and physiologist who not only was the first to describe protoplasm, he described the Purkinje fibers in our central nervous system, and he also prescribed the Purkinje images, which you sometimes hear as Purkinje Sanson, in honor of Dr. Sanson, who was a French surgeon and ophthalmologist who learned and taught about these images. But basically, there's 4 of them. And the first 2 come off the cornea, one off the front of the cornea, one off the back, and the second 2 come off the lens, the front of the lens and the back of the lens. But the first 3, Purkinje 1, 2, and 3, are upright because they're coming off of a convex mirror. And the 4th, since it's coming off of a concave mirror, is inverted. And the Purkinje 1 and 4 are the ones that actually are used in a lot of tracking technology because they can be very reliable. And a lot of diagnostic instruments will use it. But on my microscope, the Purkinje 1 looks like, I think it looks like kind eyes. And the Purkinje 4 is inverted, and I feel like it looks like almost like sinister eyes. And you can use those to center both the capsulotomy and the implant. And like Dr. Packard said, both need to be centered, the capsulotomy and the implant. But you can see here, Purkinje 1 is the brightest and looks like the kind eyes. I just pointed at Purkinje 3 and the vitreous. And Purkinje 4 is the inverted. And you can see when the patient fixates, that's a very unique relationship for that patient. And the reason I like to know that relationship is sometimes with anesthesia, they can't fixate. And I need to recreate that relationship as a surrogate for patient fixation. So if someone's looking off axis, Purkinje 1 and 4 aren't aligned. If they look the other way, they're not aligned. But when they fixate, there's a very unique and consistent relationship between Purkinje 1 and 4 that I use in every single cataract surgery that I can use. And let's say I'm looking at my microscope and it's someone like this that kept looking a little superior, a little bit of bells. They had anesthesia and they would not look directly at the light. And I can use my 0.12s to align them. And then I can center my capsulotomy and my implant. So I can do this manually if I have to. This patient was another one where I could use my manual technique and mark the corneal surface and then perform my manual capsulotomy. And this deserves the time and effort. I call it a refractive capsulotomy because it's so important for long-term implant centration and to minimize any decentration. And so we all know how important this step is, but when you're doing it manually, you are following a corneal mark to do a lens-based procedure. So you're constantly having to adjust for parallax. Whereas in this case, I was able to do that and I achieved beautiful 360 degrees of anterior capsule overlap. But that's not always easy to do manually. So Zepto was developed with a push rod to push the silicone house and the nitinol ring into the anterior chamber and to use the same Purkinje method. I have 1 and 4 aligned perfectly. And then I ask for suction. And the silicone housing sucks beautifully to the anterior capsule. I deliver the energy. There's energy delivery. We release with a flush of BSS. It actually creates a nice auto hydro dissection. I have a nice capsulotomy. And then I can go ahead, because I know my capsulotomy is centered nicely on the patient's visual axis, I can use it to guide my implant centration. And so when I place this multifocal implant, when I know I don't have 360 degrees of overlap, I know there's a happier spot for that implant in the capsule, and I rotate until I get that capsule in a beautiful place with the implant. So I can use both the Purkinje and the capsular edge for centration. And this patient did absolutely beautiful. And so the Zepto technology works great. I'm trying to achieve this overlap, and whatever is your favorite method. Femto taught us so much about how to do a great capsulotomy, and things like capsular laser and using your best manual techniques or using Zepto, whatever is your favorite. I have just found really good luck with Zepto. Here's a light adjustable lens. And one of my favorite combinations is Zepto with a light adjustable lens. I've had beautiful, beautiful results with the light adjustable lens technology. And you can see how this capsulotomy did beautiful over time. I did publish this in the ASCRS journal, and it actually won the Rosen Award at the ESCRS last year for best new surgical technique. If you want to read about centering the capsulotomy and the implant on the visual axis. Thank you.
Thank you so much, Vance. It was amazing talk. We learned so many things, how much important centralization during cataract surgery. So we may have some questions to you, but we will continue after Arthur Cummings' talk. Thank you. You spent time with us between your surgeries. Now we will move Arthur Cummings. He's from Ireland. I was really looking forward to listen Arthur, because we changed topic. We talk about cornea, we talk about cataract surgery. Now we will talk about something different. This is robotic surgery. Maybe this is future. Now we will listen to you. Thank you so much for accepting us.
Thank you, Aylin, and thank you and Michael and Chris. It's such a lovely event, and I'm so thrilled to be part of it. And I've so enjoyed the talks. Vance, I love the talk. I can see why it won the Rosen Award. It's such a nice talk, but I've learned from every speaker tonight. It's been fantastic. So when I asked Michael, what would you like me to speak about? He said, whatever excites you. And I said, but there's so many things that excite me. There's Allotex, there's the light adjustable lens, there's new lenses. And he said, no, do something that most people probably are not aware of. So something that I really like that is this new KeraNova Femto Matrix. And it fits the bill because it's currently undergoing clinical trial. It's in the very early phase of clinical trial. And hopefully we're going to be involved with the clinical trial later this year. But I want to share with you why I think this really has a place. These are my financial disclosures. And up until last year, I was a member of the scientific advisory board for KeraNova, but due to conflicts with, I couldn't continue, unfortunately. But it doesn't mean I don't love the technology. I still love the technology. So why KeraNova now, and why now, choose femto cataract as a topic when so many people are suggesting it mightn't be any better than regular phaco? So I'm going to ask a few questions. One is, has femto cataract had the anticipated success? And I guess if we're really honest about it, we'd probably say no. The uptake is still quite limited, although those who use it are using it more and more. So what's different about KeraNova? Why am I excited about this? And why I think it's just a question of time and femto cataract will become a lot more common. So the way femto cataract works for most people today is often there are two theaters involved, one for the femto, one for the phaco. There are often two surgeons, someone doing the femto, someone doing the phaco. The patient often has to move, or the trolley has to move. And there's certainly three distinct phases in the surgery. There's the femto part, the phaco part, and the IA part. And potentially, with this technology, this is how things can look one theater, one surgeon. The patient is on one bed or one trolley, doesn't move around, and 2 phases to the surgery, just the femto and then IA. So it changes the flow in a big way. So the device looks like this. It's very, very high technology. It's got a robotic arm that in fact is the ROSA arm of neurosurgery. So it's even more advanced than Da Vinci. It's got in the laser head, it's got a real-time OCT. Then it has an onboard, all the fluidics, IA, and a phaco. So the idea is that the phaco will be used very infrequently, but it's there on the odd time you might need phaco to break something up. And then it has included an integrated intelligence for energy modulation. And I think this is part of why it's so exciting. So basically what happens is a beam, the incident beam comes in and now strikes a phase mask. And this phase mask can take on different shapes to give you a splitting of the energy beam into multiple spots. In this case here, it's into 9 spots. So you've taken one pulse and suddenly created 9 pulses out of it with the same energy. And that's what the phase mask does. And that's why it allows one spot to be multiplied multiple times. So if you look at the spots over here, the device, the example I'm showing you now is applying 6 spots per pulse. So 1 pulse gives you 6 spots, 2 pulses gives you 12 spots. And if you're doing 5 pulses, you're getting 30 spots. So typically you would need 6 pulses to get 6 spots. But now in the time of 6 pulses, you're getting 36 spots. So the volume you're doing is a huge amount more. And if you look at a conventional femto, if you want to do 12 lines of femto, this is what's happening. You're doing the line of femto, you're then doing a U-turn and coming back with a second line, and then doing a U-turn and then doing the third line. And the time for doing a line is the same as the time for doing a turn. So in that block of femto, there are 23 steps. If you now look at that with the femto matrix, there are 3 steps. There's the first step, which is doing basically half of that volume. There's a U-turn, and then the second half of the volume. So really, it's up to 20 times faster, depending on how you've set this up. But in the time that you get 2 lines done, you've got this whole block of work done. So it's obviously a whole lot faster. But it's not just about the speed. The fact that it is faster allows all the other logistical efforts to happen. So there's a very revolutionary energy management system. And this is the part that's really so innovative and intuitive. So there's an OCT guided process called the threshold scanning system that looks at the tissue threshold for ablation within different parts of the lens. And so what this does is it enables an energy customized lens treatment. And then using the threshold scanning system, the femtomatrix laser can apply the exact amount of energy for the most efficient photoemulsification across the range of the cataract. So it tests in different areas with air bubbles, and it dictates or determines the threshold of power that's needed to create an effect. It does this over a large zone. And then before it starts the treatment, it now has a 3D map where it knows there's certain parts of the lens that are going to need more energy and other parts of the lens that are going to require less energy. So the problem is that if you have the same energy all the time and you simply distribute this through the lens, you're going to find that it doesn't work perfectly well because different parts of the lens have different energy threshold numbers. And so the result is if you're in an area of the lens where the energy level is too low for that area, you get no effect. And conversely, if you're in an area of the lens where the energy level is too high, you get a whole lot of bubbles. So the solution is to do this automatic threshold scanning based on the OCT imaging. It takes about 10 minutes to do this, not 10 minutes, 10 seconds to do this across the entire lens. And then it plans the treatment in such a way that every part of the lens is going to get the appropriate amount of treatment. So the very first step is putting 8 spots in with energy defined that's increasing. The energy is increasing from 0.7 to 7.4 microjoules. The second step is the OCT now determines how big the bubble is that's created, or the bubbles that are created, how big they are, to determine what the energy threshold is. The third step then is to do these 2 steps, the energy and the determination of the bubble, in 24 different locations in the lens. So you now have this 3D map of what part of the lens needs what. So there's certain parts of the lens are going to need 9 spots within the phase mask. Other parts will need less. And so you get a completely customized energy level for the lens. And it gives you within 30 seconds, whether it's a hard lens or a soft lens, within 30 seconds, you have 15,000 small cubes within the capsular bag, all of 200 microns by 200 microns. And they are suitable for IA. All they need is IA. And the very first eyes were treated in December of 2019 by Pavel Sedulka in the Czech Republic and was done with 0 phaco. So this is the first case. I'm going to go through a couple of things with you. It's just a minute long. So the robotic arm settles down on the patient. This incident beam goes in, hits the mask, gets multiplied into what it needs. It's done the calculations, so it knows what to happen. It's chosen 6 spots at a time. You can see how quickly it's done the block, while on the right-hand side, regular femto is still working. This is robotic docking. So it finds the eye, docks on the eye, apply the energy to the lens, and then the energy you're applying now is exactly what the lens is needing. So there are no additional bubbles, and there are no parts where the lens hasn't been cubed. It then does the rhexis and the corneal incisions, and now you have these 15,000 tiny blocks. And because they've all been broken up, whether they're soft or hard, is they simply aspirate. And you'll see in the live image, taking some time just to get through the initial break. And once you get into the cubes, you start aspirating these cubes, and they come away. And as far as I know, the numbers are now something in the 20s or 30s. And so far, every single case that has been done with IA only. So the phaco is on board for the times that you think you may get stuck. So this really changes the dynamic in the conversation. So in summary, from what I've seen and heard so far, it seems to be extremely effective. It's very efficient. It seems to be very safe. It's very intuitive. To tell you the honest truth, when I first heard of femto, and it was at one of the AAOs, and I thought, my word, this is interesting. So now he has a device that does this for us, and all we have to do is remove what's left of the lens. But we know it wasn't the case. We're going to do phaco afterwards. And the logistics are good. There's an excellent patient flow. We know there's been a conversation recently about aerosolization with phaco. I don't know how big a deal it is. I don't think it's a very big deal. There are ways of working around it. But in fact, in this case, it just doesn't exist because the lens has been emulsified to a point where you can do IA. And that's the end of my talk. And that's why I'm so excited about it. I really think it's going to make it safer for patients, more efficient, quicker. And I think it's going to make it a logistically an easier procedure to do. So thank you very much.
Thank you, Auffarth. So we want to use a couple of minutes for a round of discussion. And I would like to start with Richard. Richard, are you?
Unmute.
Oh, unmute, Richard.
There we go.
There you go.
Richard,
yeah.
You know, there was a couple of technical problems. Maybe you can quickly summarize the end part of your lecture, just to.
Yeah, sure. I mean, what I was, after the video, which was supposed to show the capsulotomy in 0.3 of a second, we're then discussing the various investigations, and the CE mark study showed us that we could produce with great accuracy size, centration, and circularity. And we also, I would have shown that this device has been used in all sorts of complex cases, white cataracts, membranous capsulotomy, whether the capsular membrane, small pupils, pseudoexfoliation, and so on. And it seems to work extremely well in all of these situations. As far as excitement is concerned,
Hey, Richard, you're gone.
we all know we can't do manual capsulotomies as accurate. We now have premium lenses that our patients are going to get better results. This means we as surgeons are going to get better results.
Okay, a question that came from the participant is there there's a docking involved, but is there also an eye tracking or some eye registration involved?
No, there is a flashing light the patient can fixate on to provide centration if you want to, or else, as with what Vance was saying, you can use the Purkinje images to do this. There isn't any docking involved. The only contact between the patient interface and the cornea is the HPMC that just helps it to attach to the surface of the cornea.
Right. Any questions from the faculty to Richard?
I just think, well, I've had some experience with the laser myself, so, and I am also involved with the company. But Richard, do you want to elaborate about some of the evolution of the laser in terms of speed and why?
Well, absolutely. In fact, the latest iteration, which nobody has yet tried but has been done on pig eyes, it's down to 1/4 of a second. And they've also changed the spot size over time so that the energy has been reduced and reduced and reduced. And you may have seen on some of the earlier videos and slides that people have shown that it looks as though that there is a sort of furry ring around the edge of the capsulotomy when it's done. The latest devices, this has virtually disappeared, because what this is actually is a little bit of coagulation of the cortex that the laser has done, because there is a heat process. And you'll see something very similar, in fact, with Zepto, because the process of what is actually going on at the capsular edge is also very similar. And over time, the device has been made easier to use in terms of the patient interface, the focusing, the speed at which you can do it. And I mean, Sheraz, you've seen some of these iterations over time as well.
Yes, I mean, I think it's quite amazing to see how technology is evolving. But one of the things with all technologies is initially when you come up with this concept, and you're bound to find it's quite different in the laboratory than it is in the live patient.
Yeah,
and
absolutely.
you realize that there are things involved here. This is still pig's eye that you're playing with, but when you've got a human eye, you've got to adapt towards it. There are so many other variables that come along, and that's where all technology companies, and where there's innovation, really require a board of medical advisors to come up with solutions quickly, based on previous experience and thinking a little bit in left field and out of the box. So this is what we've been doing with capsule laser, and it's been quite interesting to see the rate of progress. And one of the other things that I find with technology is progress doesn't take place in a slope. It takes place in big steps. You suddenly solve a problem, and your game is improved. It's a bit like playing squash. You suddenly get that stroke right, and your whole game changes. The same with technology as well. I don't know if our other panelists have observed the same thing. You've all been involved in developing technologies. You sort of hit a brick wall, and then suddenly it all changes. Has that been your experience as well? I mean, that's certainly been ours with capsule laser.
No, Sheraz, you're absolutely right. And I'm in the process with Lucia Barato of editing a book on the history of refractive surgery. And as I go through all of the chapters with all of these pioneers, you can see that there are sudden step changes when somebody has an aha moment and they realize that what they thought was a problem wasn't actually a problem at all. It was just that they hadn't actually found the solution. It just disappears. And then the whole thing goes crazy. I mean, I've just been editing today a chapter on Jose Packard, and the changes and the steps that he went through developing his original keratomelusis techniques, keratofaker, and all of these things. And you could see how his mind was working and how he would suddenly present himself with a solution to a problem. And I mean, I see you smiling, Arthur. You know what I'm talking about. Michael, you know what I'm talking about.
I agree with you, Sheraz. Absolutely. I think actually those hitting the brick wall is a really nice thing for anybody who's involved in innovation, because that's when you keep banging your head against that brick wall and suddenly it disappears and you find this big, beautiful, something outside, that view outside, which is absolutely amazing.
So I think we're all
You're
optimists.
right, Susan.
We're all optimists, and I think that I suppose the message to the audience out there is you don't. If first you fail, just keep trying and keep trying and keep trying, and have faith. You eventually get there. It's wonderful when you do. You can revel in that sense of accomplishment.
Shiraz, you're absolutely right. Last Saturday, if he had still been alive, it would have been Charlie Kelman's 90th birthday. And if anybody spent time banging their head against a brick wall and then finding a solution, he was the perfect example.
Right.
So I think that's a very exciting input from all those guys. You're being involved in innovation. So maybe elaborate a little bit more on that. So you probably have a couple of younger ophthalmologists on the session. What is your recommendation? How to get involved in new technology? What are the steps? What to consider from clinical point of, maybe also from a collaboration point of view? Maybe Gerd, do you want to make a comment on that? What would be your comments or suggestions for young ophthalmologists to be involved in new technologies?
Well, maybe younger ophthalmologists are really a good group of people, because they didn't go through a lot of things that older ophthalmologists went through. Because a lot of times you have some innovative stuff, you hear from others, oh, we have seen that this doesn't work or this doesn't work and so on. And younger ophthalmologists may be more open to these things. Of course, they don't have the experience from previous developments, but they may be more open and go with more fresh minds to certain things. And some of the older ophthalmologists think, oh, this doesn't work because at that time, 15 years ago, it was not good, but things have changed. A lot of things have changed. We have other diagnostic tools, we have other biomaterials, we have other implants. So suddenly things open up, which were closed for a long time because of a basic problem which was inherited to the time frame when first ideas came on the market. If you go back, a lot of things have been already tried or invented 20, 30 years ago and didn't make it. And then suddenly they come in a different kind of clothing back on the market. And I think that younger ophthalmologists are more open to that. So don't be have too much prejudices for this. And I think this way they can be a big help in getting into this, kind of being a rebel compared to an old-fashioned ophthalmologist. So to be innovative, you must be a little bit rebellious, so to say, and not be too conservative. And the mixture of both, of course, will also be quite interesting. But I think the younger people have this kind of approach. I think maybe I'm wrong. What do you?
Vance, on that, you shared with us your first septo surgeries in South America. How many sleepless nights had you before doing that first procedure?
Well, it is interesting. Just to comment, first on innovation, I think that, here I am, I've been in now 82, FDA monitored clinical trials, mainly device, mainly IDEs. And I think that it adds a wonderful dynamic to the practice of medicine. We all love being doctors and researchers and taking care of people. But I think if you want to be an innovator, you need to, first of all, be curious and always be trying to think about how things could be better, and to be motivated to do that, because most of the innovation I've been involved with has been other people's ideas, my comrades who are on this program right now. And so, but when you're sitting there and you're trying to come up with a good idea, there's a lot of ideas out there, and there's a process to go through, and there's great advice to get from others, whether it's the magnitude of the problem, not just having an idea, but what's the problem it's going to answer, and how innovative is the solution. Sometimes it's good to start with a little intellectual property so that you can, or at least under a non-disclosure agreement, get other people's opinion as you look at things like market size and do a competitive analysis and look at the business model and really, try to figure out everything that goes around an idea, not just the idea itself. And so for me, when I'm thinking about innovation, lots of times it's, again, someone like one of you, where I'm looking at the people and the team, and it just adds such a wonderful dynamic to the practice. And so when you're getting ready for a first time, like that Zepto in El Salvador, you've practiced on iBank eyes, you've went through your preparation, you aren't taking shortcuts. So that first time, you've tried to minimize every possible variable that at some point in time, you need to do it on a human in a responsible way with proper informed consent and proper oversight, typically by an investigational or institutional review board. But there's a process to innovation, and it's really what helps drive us forward. And there's no better profession for it, in my opinion, than ophthalmology.
Wonderful. Auffarth, you know, the both of us have gone over the last 20 years to a couple of innovation cycles, you know, some very successful, some would be better not talking about. A question to you, you recently have the experience of being involved in very small companies, a couple of handful of people versus now being involved in a multi-gigantic global organization. So where's for you, where's your heart and where's the fun?
I think the fun is, we've heard it before from all the speakers who've spoken before. And I think the fun starts with, if I have a young ophthalmologist who's interested, I'm going to say the first thing you do is when you see something you're excited about, go and speak to the company and tell them you're interested in getting involved, you'd like to help them. And so some of the things I see is, Michael, you've been on many of these ad boards too, is the people around the ad board are all very, very bright. The scientists and the engineers, they are super bright. They sort of have the answers, but they're just looking for the medical input. And so when you're sitting there providing input, they don't expect you to redesign a device, or they're just looking for your honest observations. And I think that's a very good place to start. And as you become known as someone who gives constructive criticism, you're not afraid to speak up when there's something to say, but you don't hog the microphone the whole time. I think then you start learning from your colleagues and you start adding value. They don't need a design input from us necessarily, but they want from the young doctor, they want honest feedback. So where does it lie? I think it still lies with the heart of innovation is small companies doing things. And even these very large companies, of course, they have big R&D budgets and they're big R&D teams, but they're also very open to what's happening with smaller companies. And today across our industry, it's quite common for the bigger corporates to select smaller companies and do what they call skunk works for them. I think it's a very nice way to do things. The big companies, there's so much regulatory restrictions around them on what they can do, that you can give a project to a smaller company that can move much quicker. And once you get to a point where you think this proof of concept is really valid, you can then put it into a different channel. But I think where the real fun happens is when you have this idea and the first trying to prove that it's going to work.
Thank you. I would like to thank again all the speakers. Just to conclude, I would like to make a brief announcement again. So we're in the planning for the next meeting, which is going to happen on the 22nd of July. We have again an outstanding faculty that we invited, and we would be very happy if you can join us again. We're going to put out the presentations on YouTube as a video. So if you want to see and review some of the presentations that were really excellent. I'm closing this meeting, the session. I would like to thank all the participants. Especially I would like to thank Professor Kilic from Istanbul for the moderation and organization and keeping everyone together for this seminar. Chris, thanks for the organization, and I wish you everywhere a wonderful day and a wonderful evening. Thank you very much for joining us. Bye-bye. Bye.
Thank you. Bye. 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 Bye.